As we kick off today, I'd like to introduce to you the keynote speaker. Our keynote for today's workshop is Emmanuel Nyirinkindi. He's the Director of Transaction Advisory Services, International Finance Corporation at the World Bank Group. He has established an incredibly strong record of leadership and execution in advising government, in designing and bringing to market commercially robust public-private partnership projects that provide high-quality, affordable, and efficient infrastructure and social services to the public across a variety of sectors. So with that, I'd like to welcome Emmanuel to open up the workshop and kick us off for a productive 2 days together.
So thank you, Alison, and thank you to the forum for inviting me. A small personal note, my dad was an orthopedics assistant and wanted me very much to go into medicine. I didn't have the blessing to go into that field. So PPP is actually a personal passion in the health space because I feel a little bit it's a contribution I can make into doing that. So I'll just share that with you. My topic today is how we do PPPs, why we do PPPs, what are the considerations we have for PPPs, and I very much want to share some examples across the globe that we've been involved in. What you see in front of you is a picture of a gentleman called Ruben. Ruben is a rural farmer in India who works for less than $2 a day. Ruben is a father of 4 children, was married to Shaila. Shaila was ill. Ruben needed to get to a CT scan 100 miles away, pay $65 for her to get a scan, was unable to shortly after Shaila passed away. Human beings are at the heart of what we're trying to do with PPPs, and bringing services to them is completely central. So what numbers are we talking about? 400 million people are estimated to lack access to basic health services. And the fact that they have to pay for them, right, when they have very low incomes is really problematic, right? So this is the motivator for trying to do more by bringing private sector efficiency, expertise, together with public funding to provide a public service. And you saw the definition in the slides about what we do with PPPs in general. So what are some of the challenges that are faced with PPPs? There's increasing demand, there's rising costs, there's a lack of infrastructure, a lack of trained people to treat patients, a reliable supply of medicines, and then you see a lack of efficiency that just makes everything more problematic, and therefore a low quality of service that is given to the sick. The UN and the international community in 2005, as early as then, spoke to the need for people to have access to services, but not to suffer financial hardship when paying for these services. So it's important for people to be given treatment, but for them to be able to afford that and for them not to be turned away because they can't, right? So by 2012, there's a general recognition that governments would need to be involved and that they would need to accelerate this transition towards affordable healthcare and also quality healthcare. So both those things are critical. The fact that universal healthcare is in the Sustainable Development Goals is for us an important indicator that actually you do need that political commitment to bring this about, and that governments are critically important in understanding this. And then the question is, how do we bring the private sector into providing more, particularly of infrastructure and service, as opposed to just providing the things that are used to treat people in the public sector. So what are some of the pillars for universal health coverage? There would be access, so people have the availability of equipment and treatment, right? That there would be equity. The poor and the rich can also access facilities and resources. That there would be quality of service and also outcomes, and that there would be affordability. Those 4 things are the critical things you need to get right. So we have public sector provision of health, and we also have private sector provision of health. And each of these 4 pillars, they are, in a traditional sense, a bit different, the impact and what people have. So typically in private sector provided healthcare, you tend to have access to both equipment and service, right? That's a feature within private healthcare. People pay because they will have service and that they will have good service. So quality is kind of something we expect from the private sector. Otherwise, it's not a sustainable business. You have bad quality, you have bad service, people will walk away, your business will die, right? You have a limited equity when it's in the private service because those who can afford can access the service, but those who can't struggle, right? So this is a feature we tend to see in public service provision, because then the rich, the poor, you both access the same institution because you are a citizen or a member of the community that's benefiting. And then it tends to be more affordable within the public sector. So how do we bring the benefits of funding to try and solve both the issues of access and equity in the private sector, and also how can we bring the benefits of efficiency of the private sector into the public sector? That's essentially what we try to do with public funding. So social health insurance is a means by which providing additional resources, so particularly those who are not able to afford, are helped to afford access into the facilities that are available with the private sector. And so you have more equity because then somebody is financing for the for the more poor to be able to access facilities, and it becomes more affordable for them, right? Now, with so that's what that slide is showing. With PPPs, what we feel is this is a means for the public sector in particular to be part of the financing and also part of the licensing, bringing the private sector to bring the benefits of access and also quality into public sector provision. So that's part there, and then there's a balance. So in your slide set that came before, there was a definition that the World Bank uses for what is a PPP. Essentially a long-term arrangement, contractual arrangement, that shares risks among those who are best able to manage them with a view to providing a benefit, and that's a standard definition. So some conditions we think are critically important to get good PPPs. One, it's an arrangement between the public and private sector, right? And public typically is funding, private is providing equipment and supply, and I'll talk to that shortly. Services are for the provision of services is actually by the private sector. The investment will be mainly by the private sector. There will be different types that I'll talk to shortly, where some of that investment may come from the public sector, in fact, even predominantly from the public sector. The time period is typically a specified period, so maybe 5 years, 20 years, even longer than 20 years. As an example, I'll share of a 99-year period. The intent is to share risk, right? Who's going to be responsible for managing patient demand, and who's going to be responsible for doing construction risk management, so that a 2-year project isn't a 10-year project, and people are able to access that. The focus on quality of service and performance is critical, right? Because what you're interested in is not so much that you have a gleaming building and good equipment, but that you have healthy people who are being served by the infrastructure. And lastly, it's very important to think about who's going to be paid and how they're going to be paid, so that there is not just a building that's paid for equipment, but that's sustained throughout the lifetime of the concession or the infrastructure. So final responsibility for service delivery in a PPP remains always a public sector responsibility, even though execution is with the private sector. Yeah? So different types of PPPs. You have the range from somebody is providing non-clinical services. They're not touching patients, so they're providing such things as cleaning or catering or maintenance, and we have that happening all over the world. Different parts of the world, they do it differently, but all over the world we see this type of PPPs. You have what are referred to as privately financed infrastructure, which tends to be construction of buildings, right? It's the technical lingo. One is responsible for designing, for building, and for managing facilities. This is very much found in the United Kingdom, a number of countries that I've given you examples that do this. We have countries that have chosen to do management contracts. They build the infrastructure, but then they have the private sector run the facilities once that's built, and the intent here is to bring the private sector into managing and maintaining facilities. Then some countries have gone out and done clinical services, so they will bring the private sector into providing any one of that range of services, and that might be in a facility, but you're asking for the service to be delivered within a particular facility. Vouchers and insurance has been a way in which, when I spoke to the slide set, when I talked about equity and access being done through the private sector, you provide funding so that people can access healthcare, even including in the private sector facilities. Lastly is integrated PPPs, where buildings and treatment of human beings come together, and the responsibility for providing the both is actually done through that type of PPP. So a variety, and then I'll talk to kind of how these are done in three broad cluster groups, right? So the first is health infrastructure PPPs, essentially the buildings that are used for treating human beings, and also the equipment that is used for treating, but does not include treating the human patient. So these are provided, and the public sector will use the both to treat patients. Then you have clinical services PPPs, which now the additional feature is actually dealing with patients, right? Then there is a different set which is called a health continuum PPPs, which the intent is to go a little bit beyond just the clinical services, but actually go upstream and try to deal with how do you adopt a community and then become responsible for making sure that you minimize even the instances of health. So starting to treat things like lifestyle diseases so that the cost of care is managed throughout the life cycle of a patient and in particular of a community. So these three broad ones actually encapsulate the 7 that I mentioned before. So let's talk to privately financed infrastructure, which is mainly, again, about the infrastructure and not yet about the treatment of patients. And here I want to do some schematics so we can see how this happens, the flow of payments, treatment, and what happens with patients. So to begin with, I said healthcare is a public sector responsibility. Typically, this will be the Ministry of Health of any country or municipality. They have a PPP agreement, the long-term contract I referred to, and then they get into that with a private sector partner, right? The private sector partner brings a capability that the public will procure or tender for. Typically, it will be about constructing infrastructure, and also would be including non-clinical operations for the privately financed initiatives. So that's the flow, public sector contracting with a private sector partner. Clinical services would then be delivered to patients, and they would be delivered by the private sector partner through this contract to the public sector, and they would expect to receive a payment they would expect to receive a payment, right? So I apologize. The clinical service is actually delivered by the public sector in this instance, not through the private sector, right? So the infrastructure is to the public sector, but the treatment is through the public sector. In return, they receive a payment, and that's the cycle. So what are some of the benefits? Typically, you have a faster construction and equipment procurement, which is a concern to many officials, and you manage the cost of the risk of cost and time overruns by passing that on to the private sector. You have KPIs, you have enforcement mechanisms for when there's a delay. That delay is the responsibility of the private sector. Importantly, then you don't have brand new infrastructure on day one and 10 years later. You actually have everything is out of cycle, everything is old, and Poor people are now not able to access anymore the best technology. Right? So equipment maintenance in many of the jurisdictions we operate in across the world, this is a key consideration. So what are some of the challenges we need to be conscious of even as we do this kind of PPPs? Because not everything is rosy. It's not just PPPs solve every particular thing. There are challenges with every particular model. So a number of them is you would have shining infrastructure and then you didn't manage to size demand properly. You have a white elephant. This is something that can be really problematic, right? So the balance of year one, you need to kind of have enough capacity for year 5, 10, and then how do you build up into year 20, right? You need to get that right. Otherwise you oversize, then somebody is paying for that excess demand. Because these are privately funded, the cost of financing is a bit more affordable in countries where one can access private financing, and less affordable in countries where others can't get private financing. So the use of local currency, the availability of financing is something that's critical. Typically, when we're working with governments, is something that we spend a lot of time on to make sure that this is not inordinate and is something that governments are able to manage, right? So they might put in more public money than just private money, but is a consideration. I think it's a particular problem when countries have a low credit rating. So if you think of some of the jurisdictions we operate in Africa and Asia, this is a very important consideration to bear in mind. Some examples where this has worked out well. So first, you will see in Turkey, this is a massive piece of infrastructure. There is a 28-year concession that has been given, but 1,550 beds have been made available through this project. The obligation is for the private sector to design, build, and manage the clinical and non-clinical services, and you have that comprising about 50 projects, so quite a huge piece. In Egypt, in Alexandria, we did a project of 424-bed capacity, mainly run through an Egyptian company, but with an international consortium behind it. It was a 20-year concession, does the design, construction, furnishing, equipment, and maintenance, right? And then does non-clinical management systems. Significant investments in a country like Egypt, $225 million, but more importantly, is 78,000 people who are getting access to this kind of improved equipment. And then an example from Latin America is one that we did in Mexico. It's a 25-year concession period, so you see the periods are different in each of them. There was for dialysis, imaging, and lab services. And importantly, here we have some data that's come through. It's been operating for a while. There's been a 33% decrease in operational costs, which is really important for the public sector because you can flow that back into more people getting more service for the same budget or less budget for the same number of people. And here it's about 20,000 people who've managed to access improved services. So that's the PFI model. I'd like to talk to the one where we now start to deal with patients. So same structure, it's public sector, they have a PPP arrangement. The private sector here has the same capabilities. Now in addition to construction and non-clinical facilities, you do have the clinical operations. So who are services being provided for? Here it is a private sector providing these services. They are provided both to poor patients, but also to patients who can afford. And insurance is coming in now where we have insurance. So payment can be done by insurance to supplement what poor people and affording people can't. And in many instances, you will find the government coming in directly to provide this financing through the budget. Okay. So some of the benefits is indeed The private sector partner is not just dealing with bringing efficiencies into the construction and the equipping, but is also through the full life cycle cost of a project, particularly where it deals with human beings. You bring in efficiencies and expertise in particularly the treatment, so the responsibility for medical personnel, bringing in people who are qualified and making sure they are available all the time is typically a responsibility to the public sector, to the private sector, and that's usually a huge benefit, right? We find that innovation and new technologies tend to be other huge benefits that come from that. And so that's why these are done. Sorry. Yeah. So some of the objectives, I think it's really important to understand what is government trying to do. You want, first of all, to bring healthcare service to be affordable to every strata, not just the ones who can afford. You want the underprivileged to come into this kind of arrangements, typically at a very low cost or even no cost where the government can afford for that to be happening. But also you want very much to be regulating, making sure that people are not, in a sense, disadvantaged because no one is paying attention to pricing in this market. For the private sector, because it's a very key player, essentially they're interested in expanding their operations in new markets. You do want sustainable cash flows because if you don't have them, then the project doesn't work. You have a beginning, but then you don't have that sustained excellence. And then, frankly, one has to pay attention to the sizing issue I spoke to so that you're not having too much capital that's not really in service of the patients and people are actually paying higher tariffs than they should. Okay? When you have this balanced, then you have quite a good project. So examples of full clinical service hospitals, one from Brazil, 298 emergency bed hospital. This one was a 10-year arrangement, and about 400,000 people have had improved access with that number in investment. This is a unique one. It's the longest concession that I know of. It's in Shillong in India. About 240,000 people had improved access to services. The intent here is actually to both treat but also to train. The requirement for the 99 years is a legal one. The government wanted people who are doing this to also have a long-term lease and for the two periods to be matched. Right? That's the difference. It's not a 99-year period because there's a requirement to recover the financing over 99 years. There will be iterations of how they get that funding. And then lastly is a 10-year contract for refurbishing, equipping, operating and managing in a dialysis center in Bangladesh. And here we've seen 100,000 people who have access to improved investment and very much the reduction of out-of-pocket expenditures. For half of those people we've seen who are accessing these services. Dialysis is typically expensive and non-available in many of the countries we operate in. It's important to manage particular costs in this particular sector. So this health continuum PPPs is not very common. In fact, we only have one example that I know of. I'll speak to it. But here the intent is to go a little bit upstream, and the aim is very much to manage not just people who come in who are sick, but to make sure that you avoid them becoming sick. The feature is very much to, in a sense, adopt a community. So the private sector becomes responsible, with the government's blessing, to have a specific and distinct population, and then be accountable for their health outcomes, even from before they're sick. So there are incentives that are driven, built into that. And so it has a lot of the features that we saw of the full clinical services. But the additional feature is that you have preventive services built into the clinical services one. So some key challenges with the health continuum PPPs, it needs to be done in more advanced societies. Why? One, you do need the patient to have an option to get treatment, not just in the private facility, but in the whole network of facilities. But to do that, the country needs to have a very good sense of who is the citizen of the community. So you need to be able to identify them. And everybody needs to kind of sign in so people have access to where they go to get treatment. So our example is actually a Spanish one, which has been extremely successful. It won the Best General Hospital Award in 2006. It's been going on for quite a while. There's been a 91% patient satisfaction survey. 91% of the patients were quite pleased with this. Shorter waiting times. It's a 300-bed hospital, and it's a 15-year concession. So that's that. What do you need to be successful with doing PPPs in a very sensitive, I would say, politically sensitive area for many of the countries that we operate in? One, we do think that health PPPs are not the objective. They are an option and a tool that the government needs to consider. They need to come within a wider health strategy. So what is the government trying to achieve? And then within that strategy, where do PPPs fit in? You need strong political will, because there will be questions all the way from why are we doing this through the private sector instead of doing it through the public sector. And private is stopping people coming in with access. Private is about profiteering with human beings. So the sensitivities we see in health are similar to those when we see the private sector in water. It's an emotive topic, and there can be a lot of ideological debate, particularly in this sector, as opposed to PPPs in transportation or in power. And even those, once you get into pricing, there's always going to be an element of sensitivity, right? So strong political will, this is what I want to do and here's why I want to do it and here's how I'm going to take care. That's important. There needs to be a enabling legal and legislative and regulatory environment. The focus needs to be, frankly, on service delivery and not very much on just the facilities, right? A lot of people like the facilities, but our view is the best PPPs. You need to really focus on why is it better for the person who's being treated and for the government which is paying for it, as also you balance that the person who's providing the service is catered for. There needs to be transparency in tendering, because we think this brings competitive pressure and lowers costs. And we do think you need to engage all the stakeholders, the people who are going to work in this hospital, the patients who are going to access it, the people who are going to finance the project. You need to take care of that, right? And then for many of the governments, because these things can become really expensive if they're not managed well, they need to understand what are the financial implications of getting in and staying in. And if you have things like an unanticipated explosion of demand, how do you handle that? Appropriate risk sharing, we think, is extremely important, because these are 20-year arrangements. If you put too much risk onto one party, too much financial risk onto the paying party, the public sector, it doesn't become sustainable. If you put too much risk on the private sector, demand that people didn't have a very good idea what would happen if you had a successful outcome, then it also quickly becomes unsustainable. So that's a tricky balance. What challenges do we face when both designing and also in the implementation, all the parties? Macroeconomic risks. Many of these things are funded with currencies that are foreign, right? So if something goes wrong and you need to make payments, right, it's typically not any one party's fault, but it's something that then needs to be handled, right? And so that's an exogenous factor, but is an important factor to handle. Typically, there will be a difference in day one from when you're doing a PPP to before you did a PPP. So the ability to monitor, one, that the contract is being honored, two, that the service and numbers that are meant to be provided are being handled. So monitoring is critical to all parties being comfortable. When disputes happen, what is the legislative and institutional basis for doing these things? When you're beginning, there's a limited experience. That's when people will tend to be, I meant this, no, you meant that, this is what's happening. So that's really important to handle that. And then the political risk of instability, this can be a big problem depending on where you are. Political commitment is important, particularly when things are going wrong, because someone has to stand up and say, this is why we did this, and it's never going to be 100% perfect, whichever environment you do this in. Just like it's never 100% perfect when you're doing it as a public project, it's never going to be 100% what you anticipated in a public-private. And so it's important for people to stand up and be, hold people accountable when things go wrong, but also support when things are being done well. So a few final thoughts on PPPs in the health space. Frankly, PPPs should not just be done because they are a financial mechanism. The financing is a good way to bring in infrastructure, but financing is not the right way to think about why you want to do this. It needs to be an aid, not the purpose of why you do that. The private sector, our view, has demonstrated the ability to bring quality, to bring efficiency, and the ability to retain and train staff in a really important area. And actually, we think this is why you should be doing PPPs in the health space, right? That they are bringing value to the public sector in terms of service delivery and sustainability. So we feel that, in particular, PPPs, when they are constructed right, managed right, regulated right, what they bring is an accountability for services which we often find lacking in public hospitals. That actually is the fundamental issue. An important caution is when PPPs have been really successful in treating human beings, then you could actually have a lot of demand, which wasn't anticipated. And this is one of those where there's not an easy way to find counterfactuals, right? How will it be before? How will it be after? You anticipate that there will be a uptick in demand. You don't have the right mechanisms to manage that. Then the problem is that you have abandoned this one facility, and then you have an underutilization of other public infrastructure. And so it's really important that governments who are doing this or public entities doing this, they look at the entire health system and make sure that the whole system, the whole network works well, right? Not just one particular piece of the network. So those are PPPs. I'd like to tell you a little bit about our small group within the IFC. I work for the IFC. I head that group in the IFC that actually works with PPPs. We provide transaction advisory services to governments all over the world, in Latin America, in Africa, in the Middle East, North Africa, in Eastern Europe, Asia Pacific. We have done about over 60 projects since 1989. So in the last 30 years, our department came into existence 30 years ago, mainly to work in the network industries, power, health, power, communications, transportation. But since 1989, we've done more than 60 health PPP projects. Of those, more than 30 have successfully closed, i.e. somebody is taken on a contract and is busy delivering either the construction or the services post-construction. 13 of them are still under construction, so the success rate for what we started versus what we finished is in the range of about 70% of those have come to be. It's about 11 million people who've accessed better health services, which is why we do this work within the IFC. And importantly, over $1 billion in private sector investments have come into an area that we think is sorely needed. I won't go to these. These will be in the slide sets that you have. But this is how we do the PPPs in terms of detail. So thank you, Alison. That's it.
Thank you. I have a few adjectives that I've put together just to summarize. Rich, thorough, cutting edge. You really outline recipe for success in multiple geographies. Let me repeat, in multiple geographies, which I think is incredibly important. You also acknowledge the complexities of dealing in the different environments you work in. And importantly, you said one phrase which I think often captures the hearts of the business community. You talked about prevention. And when you mention prevention, that leads to ROI. And ROI is a way that things are often measured. So I cannot thank you enough for that encompassing talk.